right reflected here. Okay, so we're going to start on our next session, which is Innovators in AI for Health, and it's a very interesting session. I think we have been looking forward to this session. So we'll have the innovators who have developed AI tools and which are already in use or are under late stages of development. And so I think we're going to start with Dr. Pooja Rao. She's from Cure AI. Pooja is there? Yeah.
Hi, my name is Pooja Rao. I work for a small company called Cure.ai. We're based in Mumbai, India. I lead research and development at Cure. What we do at Cure.ai is develop deep learning algorithms for medical images, chest X-rays, head CT scans, MRI scans. We're also the authors of the Lancet paper that was referred to earlier by Dr. Nomi. So this was coming from a small company the way that we are and based in India. It was a very nice achievement for us, for the small team. So let me move on to, can I move to the next slide? Okay. So first, why do we do what we do? This has been articulated already a few times in this session. But the idea is that in countries like India and in many countries across the world, there are just not enough doctors to quickly, accurately diagnose every scan that is there. And where there are radiologists in countries like India, they're all concentrated in the urban areas. The lack of doctors is especially acute outside the urban areas, in the rural areas. But really, this is not a problem that's only restricted to India. All over the world, the number of X-rays, MRI scans, etc., are going up at a rate which is much higher than we can train new doctors. The fundamental issue is that it takes much less time to sell, manufacture, install an X-ray or CT machine than it takes to train a radiologist, which is 8 years. So this is why we started to do what we do. On the other hand, in the background, about 5 years ago, we realized that computers have become very, very good at understanding images. If you look at the picture on the screen, it's a search of my personal mobile photo album. It's Google Photos. And I've asked Google to search for window. So it's picked up all my photos which contain a window. I'd like to point out how difficult this task really is. If you look at all the windows in the picture, there are some windows which are many small white rectangles on a dark background. Sometimes they're dark rectangles on a light background. Sometimes the window covers the whole image. There's only one window. Sometimes, there are multiple windows. Sometimes they're windows from the outside, sometimes from the inside. Sometimes they're not even rectangular shaped. So it's not really a trivial task that computers have now got so good at, understanding images and identifying objects in images. But really, it's not only simple concepts or concrete things like windows or cakes. Computers are now able to identify even vague concepts like celebration, birthday, sunset. All of these things can be tagged and looked for. They're able to identify multiple overlapping images, overlapping objects within the same image. So it's gotten pretty good. So on one hand, you have a shortage of doctors able to look at images. On the other hand, you have imaging deep learning technology that's become so good at interpreting images. So what we decided to do was to apply this same technology to medical images. The type of medical images that we chose to focus on is radiology images, so X-rays, MRIs, and CT scans. This was about 3.5 years ago. Fast forward to about 1.5, 2 years ago. We have now 2 products that are developed. Both of them do something similar. So the first one on the left analyzes chest X-rays. It looks at the X-ray, it says if the X-ray is normal or abnormal. It points out the area of abnormality on the X-ray, and it also screens for tuberculosis on the X-ray. Why X-rays? Because X-rays are simply the most commonly used, widely used diagnostic test worldwide. There are about 600 million of them done before surgery, after surgery, to screen for TB, for heart and lung diseases, you name it. The other modality we picked is head CT scans. We picked this one because yes, it is large volume, but it's also extremely time critical. It's urgent. People in the field like to say time is brain, meaning that even a few seconds, a few minutes, any time that you can save for a patient with a head injury, with a stroke, or with a bleed in the brain, all of brain function later on. So this is why we chose this one. We've now developed technology that identify these critical abnormalities. The way that it is used in practice is that it puts a highlight on the radiologist's work list, which means that maybe the person has 10 scans to read and the one with the bleed is at the bottom. It would put a highlight on that scan. It would also send a telegram message to the radiologist who may not be at his desk at that time, as so frequently happens in some settings in India. They get a telegram message saying, look, this is a critical scan, you might want to look into it right away. I'll talk about evidence and impact of these two technologies in a few minutes. In June 2018, a little more than a year ago, we deployed the chest X-ray TB screening technology in the Niti Aayog aspirational district, Baran in Rajasthan. The district has a population of about 1.2 million. The way that we deployed the technology is as follows. So any patient who has presumptive TB, who has a cough or anything like that, gets an X-ray. On the same day, within 1 minute, the X-ray gets read by the AI. If the AI says positive, the patient gets referred immediately for a molecular confirmatory diagnostic test. If the AI says negative, then it's the usual clinical workflow, which is 2 to 4 days before a second radiologist reads it, and then whatever the radiologist says. Over a year, we had enough data to be able to quantify the impact of this technology. So I don't know if you can read the numbers, but what the slides are saying is that by deploying AI in this manner in the workflow, ensuring that patients got an AI recommendation and then a diagnostic test right away, what happened was that we were able to see an increase in the number of new cases identified in that district. For TB, this is desirable because we're not currently finding as many patients as we need to find. What we also saw, which we maybe were not looking for, was that we had at that site, they found fewer patients that dropped out from the time of the X-ray, between the time they got the X-ray and the treatment. This is because previously the patients often had to come back 1 visit, 2 visits, 3 visits before they would get an X-ray, a molecular confirmation, and then be initiated on treatment. So we saw that as a result of putting the AI in that place, maybe as a result of the workflow improvements, there was actually fewer dropouts from diagnosis to treatment. We also, of course, saw a sharp reduction in the time to diagnosis and treatment initiation from the first visit of the patient to the hospital. Similarly, another story, this one from the Philippines, the way that they use AI for X-rays is they have mobile vans. So before they had AI, they would have a mobile van with an X-ray machine, going out into the community, taking X-rays of people in rural areas. And then at the end of 2 weeks, they would go to a bunch of villages and then they would end up back at the hospital. That is when the radiologist would read the images. Then the van would go back later to the villages if they ever found a patient and then try to get that patient back again. Now with AI, they're actually able to complete the X-ray, the molecular diagnostic test, and potentially treatment initiation within the same visit. Just like in the case of Baran. But since we have more data here, we were actually able to show that the AI was able to pick up cases that radiologists had missed. In fact, there were 25% more cases picked up by the AI, which were, of course, confirmed through molecular diagnosis. The AI has an area under the curve of 0.95. This is our own internal data, but then last that the accuracy of the AI is actually higher than the accuracy of radiologists at picking up expert positive. That means a molecular confirmed TB from the X-ray. So that's one story. The other one is CT scan. So this is the one that we published in the Lancet. Here the idea is that any X-ray, any head CT scan with a bleed, with a cranial fracture, with a mass effect or a midline shift, any of those. So all CT scans go directly from the CT scan machine to the AI. which then puts a red dot for the positive ones on the work list and sends a message. So this is an example of the CT scan technology. This one is deployed in a government hospital in Kerala, where they don't really have 24/7 radiologist coverage, even though it is a district hospital. With this one, we've now been able to show that it's saved 37 minutes of time compared to when the radiologist would have otherwise read it. So we're able to get the cases to a radiologist read 37 minutes faster than they otherwise would have been. And this is quite a lot of time for a patient with a stroke or a bleed. So those were just some anecdotes. We have a bunch of papers, which I'm not going to go into because I was told I have 5 minutes. This is where Cure.ai is currently used across the world. We're now deployed in 16 countries across 62 sites. Of course, India is still where we have our largest deployments. We do engage with the regulatory authorities where they exist wherever possible. We're also very keen on publishing evidence, validating the accuracy of the tool, and continuing to monitor how well it performs before it's deployed, when it's deployed, after it's deployed. So I'm going to stop here. Thank you very much. Thanks.
Thank you, Dr. Pooja. Dr. Pooja, just one question. You have an offline version also, it's cloud-based.
Yes, we do. So over our years, the learnings were that not everybody, especially the places where we deploy, they don't have internet connectivity, they don't even have EMR. So we now have a little box, which is an online, offline version. All the processing can be done offline. And if necessary, it can upload things to the cloud later. Thanks. Thank you.
So the next speaker would be Mr. Raghu Dharmaraju from Vadhvani AI.
Good afternoon, everyone. Vadhvani AI is a nonprofit AI institute. I'm part of the founding leadership team, and our goal is specifically to use AI as a deliberate tool for social good, especially when the world is, mostly roiled up in either hype or fear of AI, right? So the question really is, how do we use it as an explicit tool? Now, we are currently focused on health and agriculture, maternal and newborn health, and TB are focus areas in health. And universal healthcare is something that is dear to us. We are beginning to work on that, and cotton farming and agriculture, right? Now, the thing is, a lot of technology, as you know, does not really reach public health, let alone being actually scaled. And one of the reasons for that is technology gets developed in silos. And it takes a long time for folks within the systems to actually adopt it. And hence we've created an institute that has a broad set of capabilities to go from the problem to solutions to deployment, including folks such as myself who have experience developing medical devices, doing clinical studies, folks from public health, for example, from organizations such as Japaigo as part of our team, right? And not just AI. Fundamentally, a large part of our team also comes from organizations such as Microsoft, Google, Amazon, from places such as Stanford and University of Washington. But the programs part is critical for us to actually work with the programs. And we thought we would mostly focus on building AI solutions, and we already do so working with a broad swath of stakeholders, from governments to global health organizations to research universities and field organizations. But we actually find ourselves that we are spending a lot of time in helping government and nonprofits and international organizations think through about how to actually prepare for AI. What does it even mean in terms of preparing for AI organizationally? What does it mean to prepare to adopt AI solutions by evaluating them? And ultimately, we are actually becoming a hub for researchers from places such as Stanford and Harvard, and our best institutions such as IITs and IIITs to actually develop AI solutions. Because let's face it, just like most medical devices, AI innovation is going to happen if there's cross-disciplinary working, right? It's not going to happen just by doctors. It's not going to happen just with AI researchers. That happens when AI researchers, the best doctors, and public health specialists come together. So we've created an approach to do this. I will not go to this, but key things I want to call out is human-centered, as well as clinical and scientific rigor, right? And this is pretty much the 7 questions we ask before we take on some problem and say, this is what we work on. It's not simply good enough to take on really big challenges, because spaces like public health are full of really big challenges. We got to ask, is an AI solution actually possible? And will that actually make enough of a difference? It's not for AI's sake. And is there stakeholder acceptance? And I see that the text here as shown, you're missing 2 bullets there. And 2 key bullets are this. One is, do you have co-creation and piloting partners, such as public health organizations? And do you have pathways to scale? Because we have lots of shiny AI that goes nowhere, and this is true for the last 15 years of digital innovation in health too, right? It hasn't gone very far, right? So now, so our view is that of taking a systems approach and saying, how can AI help actually make the system simpler? If anyone can recognize this, this is actually a series of births recorded at a rural delivery center. And if you notice birth weights, 4 out of 6 are 2.5. You probably know why. 2.5 is supposed to be normal birth weight, and the other are 2 and 3. Nice, perfect round numbers. And this data obviously gets transcribed twice by data entry operators into, and then we have beautiful dashboards that we don't quite know what to do with, right? This is from HBNC. We have a wonderful system of home-based newborn care where 6 visits are made by ASHA workers during the first 6 weeks. Right? And the first visit usually happens within the first 3 days. And you see the birth weights recorded there as well. And now the question to ask is why? And why is even low birth weight important? Right? Low birth weight turns out to be one of the best indicators for lifelong health, and also a great proxy for overall strength of our public health systems, because it indicates everything from nutrition to actually vaccinations, right? And low birth weight, and you can look at IHME statistics. Now you see an ASHA worker, it took 3 people to weigh a baby for an ASHA worker, and supply chain issues, cultural taboos where babies cannot be touched, right? To just blatantly misreported data, as we have seen. And ultimately, the reason all this exists is it's unverifiable. Now we ask, can we simply take a picture of that baby and get accurate things such as weight, head circumference, length to start with? But guess what? Phones will become windows to health. There are a lot of other things. I know there are researchers in the room who will tell us about things like breath rate, right? Things about tonality and all that, right? And the whole point is to simplify the system, not make a new app. This can go behind into any feature, right? And what you're actually seeing is breakthrough results we just got. We are actually the only AI X Prize finalist from all of developing world, right? For this work, this is quite cutting edge. What you're actually seeing is a health worker just moving her phone over a baby. And for every frame, for you to reconstruct a 3D image, you have 2 eyes. But with a basic mobile phone that an ASHA worker or someone like that is using on the field, we are able to do a full 3D reconstruction of the baby. And that's what is quite cutting edge about it. I'll give you another example. Oops, sorry, don't know forward, backward. Right. So here's another situation where, as you see, we are not seeing the back of the baby. We are not getting the full images, all angles of the baby, right? And this is some field settings. Now, this is extremely difficult AI. All these backgrounds, blurry images, low lighting conditions, etc. So this is currently in field testing stage. We have some more development to do, but we are quite excited regarding what this makes possible. And the reason this becomes possible is actually because we are working with a wide variety of stakeholders, right? And of course, a lot of time spent on risks, explainability, etc. 3D model helps explainability. There are other ways to do this AI, but you will not have the explainability. And that's one of the reasons why we chose this. We are also the AI partner for the Central TB Division of India to help the National TB Program adopt AI solutions, besides working on AI solutions ourselves. And we identified a broad set of broad categories of AI that can really make a difference. And you know, as I was looking at QAI's presentation, quite honestly, I just feel euphoric, right? That something like this is now beginning to touch the ground. The sort of things we are working on, adherence management, and also caseload estimations, just a couple of things. So with that, let me just close. Thanks.
Thank you, Mr. Raghu. It was a very nice presentation. Any questions from the floor? Maybe one question we can take. Yeah, Dr. Brahmachari, yeah.
I think it's fascinating to get that weight. Is there a way of you can actually get that real weight accuracy? What is the accuracy approximately?
So our first use cases.
Use the mic, please. We are on the remote as well. You can come over here and.
So the first, actually, the accuracy we need with doesn't. This one works.
Yeah, it's working.
Correct. So the accuracy we currently have is basically 90% precision, 70% recall. This is specifically for what you call the weight classification. But remember, this is 6 months of work, right? With just 1,500 babies. This is already the largest data set anywhere, right? So we have just made some technological breakthroughs, and we feel quite confident that will improve. And ultimate use cases for this are things such as growth tracking, etc. Yeah, right, where you need much.
This is a great example where ethics will come in. And let me tell you why. Hospital would like to show maximum normal weight. If you look at the record, when the children are born and dead, it will say LAMA. That means left against medical advice. Because you don't want to increase the number of deaths in the hospital, right? So these are our Indian problems. So where honest accuracy you can generate, how you protect the hospital and the doctors and don't push them into television tomorrow. That's why in Andhra Pradesh children are underweight and becomes a political issue. These are ethical issues for us in India.
Absolutely.
You understand?
Yeah, and absolutely. In fact, what you'll find is we said accepted by stakeholders. Now, which stakeholders are these? Is it us sitting in Delhi? Is it the ASHA worker? Is it the doctor at the PHC? So we got to understand various angles, and they often pull in opposite directions. And hence the involvement working very closely with government and non-profit organizations. Mr. Samir, yeah.
Thank you, very inspiring to see at least an organization working on AI and specifically social work. I was disappointed not to see WHO in the partnership slide. That's a part of the point.
No, we are a partner to WHO. Central TB Division, for example, we totally work with WHO. Just visited WHO in Geneva. And our CEO is going to give a keynote response to Dr. Soumya Swaminathan's speech that's coming up.
I think it's very good that you've been doing. The question is the areas of focus. You said health and agriculture. But then we are looking specifically on the baby child health areas. Other areas of what we're exploring.
And tuberculosis, he said.
Yes. What is the investment model? Why AI for social work?
Question.
Not active again, right? And we are really desperately looking for somebody.
To speak. This requires no additional hardware, no great phones, no depth sensors, nothing, right?
Yes.
And we are aiming for inference on the phone.
And yes, and so would you be interested in basically participating in this topic?
Yeah, we would have loved to. We just couldn't plan ahead well enough. We didn't. Yeah.
That's fine if you make a submission, like spend the evening, send us a document. We can discuss that tomorrow. That would be amazing. Okay. Because so it's weight and size as well.
See, what we do is we do a full 3D reconstruction of the baby. So
Okay,
you can measure a lot of things.
But how do you get the scale? Because to some degree, do you have to have one?
You saw local generic.
Oh,
any local scale, right? That's where we are going towards.
Oh, I see. Okay.
Local scale, you know, the 6-inch or 12-inch rulers that you find
Any
anywhere.
scale, you just have to put it next to the baby.
Yeah.
So if you could, you know, jump into this really important topic, that would be amazing.
Yeah.
Love to have
And
you.
this problem statement came to us from stakeholders such as you. We didn't pick it out of the thin air.
Thank you, Mr. Raghu. I think we look forward to having your detailed presentation tomorrow. So our next speaker is Dr. Ajay Bakshi from Goode Med Technology, India.
Yeah, it's good to see quite a few clinicians in the taking the lead in developing AI tools.
Thank you. Yes, I trained as a neurosurgeon just a few hundred meters from here. And over the last decade or so, I've been leading large hospital networks as a manager, as a CEO. I've been the CEO of Max and I was the CEO of Manipal. But this journey started around a year ago when we wanted to merge computer science with modern medicine. So I understand medicine, but I don't understand too much of comp science. My co-partner is a PhD in computer science from Minnesota, and he worked in Mayo Clinic for his thesis. So together we have founded this company just around 5 months ago. And we were very influenced by this powerful paper from a group of folks at Google, which talks about the unreasonable effectiveness of data. And what they basically assert in this is that a simple model with a lot of data is much more powerful than a fantastic model with less data. I think this is obvious to this group, but this was, as a doctor, this was not obvious to me. And I started looking for data. And very quickly, I realized that this is the situation in India. We have data, and I'll walk you through the calculation on the right, but it's all sitting in PDFs or image files. And in fact, a lot of this data has arisen because insurance you don't get paid as a hospital if you send a handwritten discharge for most part, specifically the cashless part. So you do need to send a typewritten report. So somewhere in the computer system, there is a Word document or a PDF, but it's dark data. It's not queryable, it's not searchable, and you cannot build any intelligence products on top of that. So when we started estimating, so what is the size of this data set in India, of which none is available in the structured format, we think that there are at least 100 million hospital discharges, documents floating around somewhere in an insurance company, somewhere in hospital systems. These are just the private insurance and cash patients. There would be another 100 million such discharge summaries in CGHS, ESI, ECHS, because those are also typewritten documents. And if you take into account the public institutions like Tata Memorial, All India Institute, JIPMER, all of these guys have fairly good IT systems, but they are the traditional IT systems which again don't allow a lot of standardization. So within the hospital discharge space itself, and unlike the US, in India, the hospital discharge summary is quite detailed. It has a lot of information. It has diagnosis, procedures, complications, lab reports, and even the associated stuff has some of the financial information as well. And then, of course, you can extrapolate. There's a lot of OPD consults. Most of these are in handwritten notes. So I would argue that those are not substrate for this sort of work. But most of the investigation reports, on the other hand, are typewritten. And they are generated by a computer somewhere. So our goal is to bring this dark data into light. That's basically what we're trying to do. I already talked about that. And then the way we are doing it is, again, probably very obvious to this audience. We extract this data. And the second insight that I got as a non-techie was that advanced technologies, advanced natural language processing features are needed for the extraction piece, the so-called non-glamorous back-end data cleaning part. That is where the cutting edge of technology is needed. And honestly, once it is in that model that I've shown on the bottom right, the analysis is in Excel. Well, actually not Excel, because you run into millions of records and Excel can't deal with millions of records. But it's straightforward linear regression, straightforward correlations that enable us to come up with very deep insights. So we are doing this. Of those 100 million, we already have access to around 10 million records. You will be curious to know how we got that. And it's well known in the Indian, well, the global ecosystem, that data is the new oil, data is where everything is there. So people are actually hiring us. Insurance companies have hired us, hospitals have hired us to say, please come and structure this information, because the sort of expertise that my tech team brings is very difficult to hire in an operating company. Even when I was running Manipal, I could not hire PhDs in computer science to work with me over there because they have different goals in life, and that talent is quite scarce. So this is the crux of what we are trying to do right now. The model on the bottom right is actually an open source model. That's not something that we have invented. It's called OMOP, Common Data Model. I believe there are more than 400 million records from 70 countries on this model. This is built by a consortium in the US. There are a couple of Columbia University professors. There are some other health data people who are guiding this, but it's open source. So our expertise lies in structuring it rather than in building the model, because as a model, we thought it was fantastic. It's very patient-centric. It has all the information that is needed. But there was one problem. This model has the vocabularies of the US. So when you're talking about conditions, diagnosis, procedures, it can be translated to India. But when you're talking about who's a doctor, which hospital did this procedure happen in, what insurance policy was used, that codes are not there. So we realized very quickly that we have to build almost a digital replica of the Indian healthcare ecosystem. We don't have a choice. So we now have downloaded / scraped more than 8 lakh doctors from the various state medical councils. This is, again, open source data, but extremely dirty data, because the state medical council's only job is to allow a doctor to practice, and they don't care anything about, other than the fact that a doctor has a certificate, they don't care anything else about it, but we do. So we are structuring the doctor database, we are structuring the hospital database, and of course, we need to know the Indian pharma drug names and all of that stuff. So all of this stuff goes into the CDM. And finally, of course, we have a whole bunch of commercial use cases, but for this audience, I've put over there some of the research use cases. This is the last slide. We already have an MOU with the Indian Institute of Management in Ahmedabad to do a collaboration on health economics, where we're asking questions like, so what is the consumption model of healthcare in India? What happens when a cesarean section happens? How much materials get used? And actually, that answer is not there. In the hospitals, it's not there, and in the large insurance companies, it's not there. So we're building that consumption model in collaboration with Professor Chirantan Chatterjee and a couple of other great professors in IIM. We also believe this data set, of course, we are still very young, but once we reach the size that we want to reach, researchers could come and do very detailed real-world evidence studies. You could talk about predictive analytics. Is diabetes one disease, or is diabetes 5 different diseases, some of them ending up in retinopathy, some in nephropathy, and some in cardiac problem. So there's a lot of exciting research stuff that can also happen here. And I would like to invite any and all of you to write me an email, and with the caveat that the data is not ready yet, but in the next 12 to 18 months, we should have at least 10 to 15 million records in an anonymized open source system, which can be used for various research questions. Thank you very much. Is there any questions?
So one question from the floor.
So, as of now,
please use the mic. We are on the
I'll
remote.
repeat the question. If you want to record it, yeah.
as of now, what is your game plan or a business model?
Yeah, so the business model is simple, because the clients who have hired us, they want to use that structured data for building AI insights, right? And not necessarily AI insights. Actually, some of the earlier work is, the simplest work is not even, it doesn't need any AI. It's just statistical correlation. What are the means? What are the medians? In the hospital data, we are building the Indian DRG system, because we have the largest data set now. So the DRG is diagnosis related groups, and that is the way payments happen in USA and most of Europe and most of developed Asia. We don't have Indian DRG data at all. So our first goal is to convert this into a DRG, and then a hospital or an insurer can ask the question that of the say DRG 444, which is a cholecystectomy, of the 10,000 such patients that were operated last month in India, what was the cheapest, what was the most expensive, which one had the highest length of stay, which one had the lowest length of stay. So it's very powerful insights that are very useful for insurance companies, for hospitals themselves, who not only want to improve their operation, but also want to hire doctors. Because remember, there's doctor information also in there. So we can actually tell you who's the best neurosurgeon for C5-6 discectomy in this zip code just by looking at the data, because it's not our judgment. We'll show you that this is the length of stay, this is the outcome, and you choose whether you want to go for the lowest cost or the best quality or the best value for money. I mean, all those answers will come out in the next 12 to 18 months.
Actually, since you are having with so many clients, each one of them, what they are, you do the job for them. Is it going to be helping you to break the silos?
Yeah.
That is a very important.
This is a great question. So actually, our clients are not only excited about using their own data for themselves, it is being pooled in that common data model. So they are also interested to know on an anonymized basis, because we will never share with them which other hospital. Once it goes into the pool, it goes into the pool. So a Fortis cannot ask what was Apollo's data, but a Fortis can ask, so how many knee replacements happened and where was I in terms of cost of those knee replacements. So that's very powerful insight for a Fortis hospital to know, am I spending more money in a knee replacement or am I spending less? So we have to be a bit careful in not releasing information which is very sort of proprietary. But once it gets codified, everybody is excited that we want to know what's happening in the whole ecosystem. Thank you.
Thank you, Dr. Bakshi.
Please.
It will take a second. You said that you are taking data from the patient discharge summary also. So the hospitals which are sharing this data with you, have they taken consent from their respective patients? Have you thought about this aspect?
So a great question again. So the PDP bill in India has not yet been passed. It's in draft, and we've actually read it very, very carefully, and we're designing our what should I say, service contracts with the hospitals in a way where they're compliant with the PDP bill even once it comes. But the basic point is that there are two parts of the job that we do. First is hospitals have PHI, right? So we go there and do the structuring. We build the CDM for them on their system. So that's fine. It's on their server. It doesn't leave the hospital. So there is no real problem there. Once it is anonymized and codified, then the hospitals are actually saying this is okay because this is retrospective data. When we are talking about, say, the question that if you want to know which surgeon is the most appropriate for you, you have to give me a consent to say that here is my diagnosis and please find me an appropriate doctor or hospital for this. So that will be covered by the consent. So the forward-looking, what we call the flow data, will be covered by consent. The past data is already either on the server or it is codified and anonymized and it doesn't require consent. So that's the current. We have talked to two of the top law firms. They have spoken to all the experts because this sort of a model has not emerged in India yet, such a large data set. So we are actually very confident that not only are we on the right side of the law today, but even in the next 5 years as the Indian law becomes more sort of clear, we will be very compliant with that.
Thank you, Dr. Bakshi. I think we'll move on to next speaker, Mr. Narayan Rao. I think I'll request the speakers to stick to time, and the small incentive which I can offer is that there are some AI tools on display downstairs. So if we save some time here, we can go and spend some time over there before dinner. So over to Mr. Narayan Rao.
Good evening. I'm Narayan Rao. I'm from Salsit Technologies. So we are primarily focusing on digital health solutions for respiratory diseases. So screening for respiratory problems is an unmet need. Lack of cost-effective and lab-free methods for early diagnosis like spirometry and Xray, these cannot be actually available in remote and rural areas. Setting up these is not cost-effective. So the solution what we have is an audiometric evaluation based on the respiratory sounds. The sounds we talk here are cough, wheeze and crackle. Based on the audiometric evaluation, we provide indicative information on the presence of a respiratory problem, and if yes, is it more like an obstruction in the airway or is it more related to the restriction in the lung expansion? And we also further provide how severe it is. So essentially, based on this information, the practitioner can make an intervention to make a referral or actually suggest further investigations. So we did data analysis and machine learning using about 4,500 plus data points till date. Our focus areas primarily at this moment are asthma, COPD, pneumonia, and interstitial lung diseases. Progressively, we are planning to add other diseases. So this is how the device look like. There is a audio recorder using which we will collect the cough sounds, and there is a wireless stethoscope using which we will collect the additional sounds. And there is an application which is running, which can actually run on any mobile phone, smartphone, or on a tablet phone, or even on a computer which has an internet. So once we collect the data, we will do the analysis and provide the report. So this is where we are. We have the functional prototype ready, and we did one clinical validation with Apollo Research and Innovation. And currently we are actually doing product testing, and we are also going through the whatever compliances are required in terms of regulatory and other things. And early next year, we are actually planning to make this product available in the market. So collaborations with medical community, we actually interact. Also validated the concept with them. As I mentioned earlier, with Apollo Research and Innovation, we did the clinical validation. We completed it, and we have submitted the reports, which we got also approval from them for the reports. And we are further doing with Nizam Institute of Medical Sciences also the clinical validation, and in touch with a couple of other hospitals where community health and medicine is also a focus. So coming to the challenges, basically these are some of the challenges we really faced on the ground. Quality of data and labeling or annotation. So essentially, if you look at in our context, there are so many respiratory conditions. So someone need to understand these conditions and the sounds when they get actually produced, which condition are they representing it, and accordingly the labeling has to be done. And one more important thing is that when we talk about machine learning, typically the standard features which we refer is, like signal processing related features and so on. But there are a lot of domain features which actually the subject matter experts can bring in, which will help actually in improving in building more accurate models. So essentially the involvement of experts in labeling the data and in creation of feature sets is really one of the challenge. And also there is a customer expectation that the validations have to be done on millions of subjects, especially when it comes to AI and ML models. As we discussed in the multiple sessions today, I think the balance has to be there in terms of the gains versus the short-term limitations, because all these AI solutions will get better and better over a period of time. And obviously, in one of the panel sessions, there was a discussion about the regulatory. So technology adoption can generate more data and make the device more robust. That's where tailored guidelines on regulatory need to be considered when it comes to these kind of AI devices. And recently, someone has mentioned FDA has come up with an algorithmic change protocol, so that it actually the algorithm can change over a period of time under a controlled environment. So another thing is identifying the optimal sample size, which is statistically significant and financially viable. This is where data collection at such huge volumes, we definitely require collaborations with medical colleges and hospitals. And also there has to be a focus on building publicly available large data sets, so that the algorithms can, the various stakeholders can actually leverage from those data sets. That's basically what I have.
So I think it's a very interesting concept. Dr. Bakshi wants to make a comment. I think we can have only one comment.
So I think as a former doctor, the auscultation technology was always suboptimal. So I think thanks for doing what you're doing.
Yeah.
But haven't you considered using the heart sounds as well? Because the same technology will work for that, and that's a huge use case. Have you thought about that?
No, basically, there are so many players who are already doing on the heart sounds. I mean,
It's already being
we want to partner with people who are already experts in this area, so that the cardiopulmonary condition can be covered.
Dr. Andrew, I think a short comment, please.
Actually, this is an excellent use case to use personal devices like mobile phones.
Yeah.
While using that, why do you want this special device to connect to phone.
Yeah, so basically you are very right. I mean, the disadvantage what we see is that there are a lot of variety of microphones because each device has its own microphone, isn't it? So there is no standard across what kind of microphones are used. But in fact, to answer your point, yes, we did collect data using a recorder and as well as the standard microphone on the mobile. So there is a little bit of variation in the accuracy when we use the standard microphone mobiles, just to make sure that it is working and the use case is being addressed to its fullest context. We initially want to go with the audio recorder, but over a period of time, we will definitely use the mobile microphone.
I think Dr. Rao, your tool is on display, right?
Sir?
Your tool is on display.
Yeah, yes.
So I think anyone who would like to have a look at it can just go down and see how it works.
One more comment. Among the modalities of data that we're looking at, we don't yet have audio data.
Correct. Yeah.
As modalities. So
yes.
it would be quite interesting if you would be interested in creating a topic within this group, because audio data is something that we don't yet have as an input.
Yeah, we will obviously be interested, but you just need to tell us what are the formalities which we need to Yeah, I mean, you are very right. I mean, basically there is a lot of focus on image and but audio is something which is.
Okay, thank you, Dr. Rao. So I would invite my next speaker, Mr. Vivekanand Reddy from Algorithm India.
Hi, this is Vivek. I represent Algorithm. It's on the back side. Yeah, it's on the last.
Yeah,
last. Yeah. So we're purely a data science-based company. We are basically building up some particular. Yeah, it's fine. So we're building up some particular pharmaceutical tools, which basically use the power of AI and machine learning. We have done some particular platforms for some particular major pharmaceutical organization. So I would basically say it's Novartis. We have helped them to work on some set of digitalization for the clinical trials. Like I was basically hearing some particular views in the ethical and regulatory part when they were basically saying that the quality of the sensors and usage of devices for basically tracking out the vitals. So we built some particular platform called Visor, which basically tracks the input from the patient. Like it calculates the heart rate monitor, glucometer, blood pressure monitor. All those particular vitals will be calculated and it will be passed on to the specific hubs. These particular hubs are basically the devices. What we used is basically from Actigraph and Qualcomm. When the telecom director basically said related to the regulatory thing, these particular things are already regulated and these have been properly tested. I just want to get into that. So into this particular development platform, so the device specific, what devices we use is Actigraph and Strive. If I just basically get into this architecture, the data flow schema. Now this is what we basically used it. Now in the particular clinical trial sites, the patient has to visit that particular site and he has to provide his particular vitals. And also there's a parallel platform which is running on. What happens is some particular devices are attached to patient. That particular biometric data has been basically transferred to those specific hubs. It can be Qualcomm or Actigraph. And from them, they basically come into that particular Visor platform. And we use some particular high stream data networks. We stream that high stream data and basically pass it into the platform in a very secure way. And the upper data is, the upper particular layer is, we basically calculate, we basically take the information which is basically taken from the patient at the site level. Now we have two sets of data. One is at the site level and one is at the biometric data, which is basically calculated from patient 24/7. This has been practically used for clinical trials in Australia, United Kingdom, and Finland. And this has been used by Novartis within that particular clinical trial, and we have done a remarkable success here. I'll just tell you why. We have collected the patient data, and the insights have been provided to them on a 24/7 platform. And there are some particular things which have been basically detected in terms of if there's any sort of readings were basically different, that particular metrics have been basically populated, and the pattern has been detected, and it has been passed on to the trial directors. And according to that, trial directors has a particular chance to respond and basically meet that particular patient. So this has been a remarkable thing which happened as part of a platform. And now currently we have a huge set of data, and currently we're working on another platform called Data 42, which basically calculates the complete 20-year history of data from the real life data, the real-time data, as well as the data which were basically coming from the trial sites. So that's how basically this has become a huge success, and it has given a breakthrough for us in basically setting up this particular digital platform for Novartis. And we'll be basically focusing on more amount of particular trials which will be going way further. And this is something the user interface, like the platform can basically have that the devices can be configured here, and we can have the number of data hubs being basically did in the trials. And we have all the particular studies basically listed in the platform. And we have the particular reports like wear time per that particular study, the wear compliance, and the battery level, all the particular information basically we can find it here based on the subject. And we're not compromising anything on the patient data. So we generally basically have the patient information based on the subject ID. And all these particular reports are available for the particular trial directors on the real time. And for this particular study, this exploratory study, this has been a success, and this will be going to be interpolated onto multiple studies within Novartis. Thank you.
Thank you, Dr. Reddy. Any questions? Okay, so we move on to our next speaker, Dr. Pritesh Sethi from Indraprastha Institute of Information Technology.
Thank you for having me here, and I'm going to take the next 5 minutes telling you all what we do at my lab at IIIT Delhi. So essentially, mine is an academic research group, but we work like a startup, so I don't feel awkward here talking in this session. So the thing that I'm going to be talking about is wash of AMR, contextual AI for public health. So that's IIIT Delhi. It's relatively young institute, grown to now we have about 2,500 students and about 100 faculty members. That's my lab, and we actually work on. So my background is in medicine. I started out as a clinician and got disillusioned by the knowledge that we actually had. Decided to do a PhD in computational biology, and was visiting faculty member at Stanford Biomedical Informatics Research before I actually joined as a faculty member at IIIT Delhi. So from that background, I would like to pose this challenge that we have when we are developing AI for India, that we need context. And we have been hearing about this in most of the sessions all through the day. And the other thing that we need is explainable AI. So this work dates from our work in public health, which we did in about 2013, got published in 2015, where we actually came to this realization that context actually is the king when we are making AI-based decisions. So this was, I will not harp upon this work, would not talk upon this work, but what it allowed us to do was to look at large data sets from public health in India, 200,000 patients collected on a single day across all of India, and then build AI models that helped us not only to visualize what happens across age groups at a public health level, but also make decisions. For example, we built decision networks on the right side, which allowed us to make this inference that if we were to improve LPG penetrance into the districts of India in a better way, we would see a 50% decline in obstructive airway disease. And that was combining disparate data sources together. So it was not just one data source, but combining them together and putting those in context. Science, I would believe, is a dark night. So my lab is essentially, we call it MEDAIM, Meaningful, Enriching, and Discovery-Led AI. And the background of WASH work that I want to talk about today is actually based on something which is very data-rich environment, which is ICU. So at AIMS, at the Department of Pediatrics, as a Wellcome Trust DBT Near Alliance Fellow, we set up this large big data, I think first of its kind resource in India, where we have 500,000 patient hours of continuously monitored data at every second interval, connecting all the machines, having these data warehoused, all done in a ground-up fashion, allowing us to build data quality measures into it. What it allowed us to do was to construct models that help us make predictions. So this is published earlier this year in Scientific Reports, where we actually used a modality called thermal imaging and used it to predict shock before it happened in these babies or children up to 12 hours ahead of time, based on a very simple medical hypothesis that when shock happens, especially the hemodynamic shock, center is warmer, peripheries are cooler. If we collected these images, we could do deep learning, we could do AI models on top of it and make these predictions, and that's what worked. So combining medical knowledge with AI is, I think, we do a lot in our lab, and I think is the way to go. Now we are taking these out into public health, where we have a device which is patent pending and can be handed over to ASHA workers. So having a non-contact, non-invasive measure of shock, for example, in dengue, cholera, etc. Again, we build tools in our lab. So this is what we build, what we call the visor application, combining everything in the networks of context, bringing all these things together. This was partly done while I was at Stanford. So it actually involves an end-to-end modeling framework from data cleaning until to the point of making decisions, policy-level decisions with the network. Some of the things that, so I'll skip this for the want of time, but the basic idea being that these are transparent reasoning engines, so explainable. These are not simple association networks, so causation. And they can be done, and you can inject prior expert knowledge as well, or you can totally choose to go data-driven. So I'll skip all these, the transparent reasoning, and then what it allowed us to do is we asked this question. We saw that a lot of admissions in the ICU, readmissions in the ICU with sepsis were happening from the walled part of Delhi, indicating hygiene, education, etc. were big features. So one of our network which told us that in the data set collected from Odisha, we found that water availability and soap availability in toilets, when we learned policy with these networks, ranked higher than medical measures and public health measures, such as number of antenatal care visits, as well as, for example, the immune markers, as well as hemoglobin and weight of the mother. So that's what I meant by context. These were disparate data sources, but told us something really interesting when put in the context of this sort of AI modeling. So the WASH thing that we are now doing is about reducing antimicrobial resistance in the community, not just in the ICU. This is a very local diagram that you see, that we start off with building dashboards to gain trust with the physicians, but then we very soon quickly move on to actually start building models which help us take decisions. So here is a paper, preprint actually, which which we call AMR Steward. Can we help stewardship of antimicrobial resistance with Bayesian artificial intelligence? So right now, for example, antimicrobial, antibiograms are the current way of dealing with the decisions, but can AI help us better? And I will be happy to talk about that more in the demo downstairs. Finally, we believe that, so this app we call WASH Karo, because we believe that information about, for example, antimicrobial resistance does not reach people who need the most. So what we did was we combined WHO resources with what is happening in the news, built some pretty involved deep learning models such as BERT and Albert, which are state of the art in AI, and found and matched these things together and found out summaries that could actually can be communicated. So making WHO report as well as what is happening in the news accessible to someone For example, an illiterate person who does not cannot read. So these are audios. So these are not just text that you will read, but audios that you can actually listen to. We are integrating visual content also into this as comics. I'm actually in discussion with Swasti, which is one of the NGOs present here, and we would love to take that forward with doing the A/B testing out in the community with this. So I'll probably stop there, and we'll just give a shout out to the Digital Delhi Conclave that we will be holding at IIIT Delhi in the coming month, 7th of December. We would like as wider as participation as possible, and would love to have you all there. Thank you so much.
Thank you, Dr. Pritesh. I would say it was a loaded presentation with multiple aspects of AI for health in one presentation itself. We can take one question because it is such a yeah.
No, I was speaking.
Yeah.
Thanks for the relations. I'm very happy to see you. I saw you tweet at one stage about this, and I wrote to you and come to focus with them. It's great to have you here. AMR, I mean, is a big part of the talking, and I think it's a very unique concept that the AI space. I think we don't have the list of submissions. I think it's something good to have, or some we can discuss that separately. So how this is going to be going and not mentor and what will be with a big focus. In fact, G20 with AMR
yes.
As a topic and visual health and second focus of
yes.
all kinds of
wonderful.
So, of course, WASH concept is also very interesting. So we just to make a comment that something to take it further.
Absolutely, would love to. Thank you.
Yeah, brief comment. You have. Yeah.
Half a question.
Yeah, you take the mic.
Maybe you can use.
You can use that mic. It's okay.
I was excited about this one. My question is about
Hello? Yeah.
Awesome. My question is about the role of experts in your Bayesian networks. I'm just curious to know whether you involve experts when learning the structure or you learn directly from the data.
Wonderful. So that's a great question. I know that can go in very detail. We usually start with very lean assumptions about the data. So we really don't start because these are many variables, and no doctor, and we can keep 7 pieces of information in our head at a given time. So if you're looking at 500 different clinical variables, it's very hard to elicit expert knowledge. So we don't really start with expert knowledge, but we allow that to happen from data. But having said that, we do build something that is reasonable from the ground up. For example, if it is a temporal model, we do not do something which actually contradicts the arrow of time. So having that as a basic setup in the structure that arrows can only go from prior to post is one example. But yes, we do not usually start with expert knowledge. We go to the expert with the models and then try to elicit knowledge and then go back to the models. Yes. Thank you.
Thank you. I think we'll quickly move to the next presenter from Visor, Ms. Chaitali Sinha. I think their tool is also on the display downstairs, so we can look at it.
Thanks so much. So after the Visor framework, we have Visor now. So at this point, the problem of mental health is pretty well understood, right? 1 in 4 in the world have mental health concerns. When we come to broad statistics of the availability of mental health professionals, it usually comes to about a ratio of 1 in a million in India. And the statistics are equally staggering across the world. And at this point, suicide is considered to be a public health crisis. So these are pretty well-known facts. And it was because of these facts when I started doing my master's training in psych that I wanted to work with communities and I wanted to work on the ground so that I could maximize impact in how I was working in this profession. And I think one of the most profound learnings of working with Visor for me was to understand how tech could low-cost accessibility with something like Visor. So what is Visor? I'll just quickly explain that. So Visor is basically a conversational AI chatbot. We're publicly available as an app on Google Play and iOS. And yeah, and it's massively scalable because of the fact that it's an app. It's literally something that anybody can talk to. Apart from being a conversational AI chatbot, we also have trained psychologists on board. People can reach out to human professionals if they want to talk to somebody and engage in text-based support. And we also have over 1,500 plus tools, which include meditations, audios, safety plans, crisis resources, all of these things jam-packed into one app. And at this point, like, our organic user base is immense. So we have about 1.5 million users already all over the world, with about 60% plus in US and UK. About 20% of our user base ends up being in India. And all of it kind of started with a couple of simple questions that we were trying to answer, right? That if you just think about someone in crisis or someone having a mental health concern, whom do they have to speak to? How do they reach out to someone? And if they want to really reach out to someone, how do they afford reaching out? And all of these questions could be answered by this simple solution, where we could create something that was extremely low friction and low cost in terms of the kind of support that it could offer. And that's your phone. Everybody has their phone on them all the time and is constantly talking to it, but also wants a response back, right? Something that we realize cuts across cultures and cuts across a lot of different mental health concerns is that really everybody is lonely and everybody wants to talk. And I think just at that very basic point, that I think is where we started working on building a conversational chatbot and trying to figure out how we could offer empathy through this. So chatbots are something that are being broadly used by now a lot of different use cases and a lot of different spaces. When it comes to the tech aspect of it, I think one of the most interesting things for us has been to figure out how to respond to sentiment the best. And that's been one of the most interesting things that we've been doing at work. And we've identified certain high-risk cohorts that we're specifically working with, which I've kind of listed out here. So young adults, maternal mental health, high-stress workplaces, major events, trauma, chronic illness. Some of these use cases also are cohorts where individuals want a lot of anonymity and a lot of confidentiality. If you've been abused, if you've been assaulted, if you're a person who's a veteran of war, you don't want people to know that you're reaching out for support, but you also desperately want support. So in that sort of a paradox, it's not enough to merely call it stigma and think that you've understood the problem. But also, I think in terms of a solution, this becomes one of the ways that people are actually able to access some kind of support. So we've had a fairly interesting user base in that sense, that I think the initial expectation was that we would largely have users who were young or who were adolescents, broadly in the 19 to 25 category, because I think that's the general stereotype when you think of a tech solution to something like mental health. But what we realized was that even septuagenarians or even individuals above 45, everyone was engaging with the app because they felt hurt. And that's something that was a common need regardless of whichever demographic I was looking at. So how we look at our mission is broadly just early intervention for high-risk populations and a listening ear for everybody. So these are our current numbers at the moment, right? We have about 1.3 to 1.5 million users active in the world. We have more than 90 million conversations that people have had on our app so far. We cover across 30 plus countries at the moment. And this is an interesting statistic that we kind of made out of our data, that we create about 1 million breakthroughs per year. A therapist takes about an hour or 2 hours to reach a breakthrough with a client. And that's something that Visor can do with someone who is using the app within a couple of minutes, or maybe even 10 minutes or 15 minutes, because we have clear scripts which are clinical and something that anyone can access when they are feeling that they are ready for this conversation. And we're doing really interesting work, both in terms of credibility and partnering up with individuals, right? So we're the #1 digital intervention and young adult service at the moment. We're top rated at 93% by Orca, with 100% on clinical assurance, and widely used by the NHS at the moment. Google's featured us as the #1 mental health app. We've done a couple of studies with JMIR and Oxford University. So That's also led some interesting results. We published a paper in which we were looking at broadly PHQ-9 data and trying to see any sort of variance that happened in just broad PHQ-9 symptoms, and we saw that the symptoms did go down with the population that we were looking at, which was primarily young adolescents. And this is something that we strongly focus on, right? That something that's really essential to us is that this app should be completely and utterly anonymous. It should be something that gives the user agency as much as possible. It should be absolutely private. So whether it's GDPR or HIPAA, we try to be as compliant to all of those guidelines as much as possible. We don't think of ourselves as a diagnostic app, but more as an app that is creating resilience within any person who is using this app. And we use non-generative NLP models. So we use only scripts that are clinically safe and validated by somebody. So not NLP that's running amok and we don't know what's happening with the user, given that we're working with a use case that's also really, really sensitive. And we have had a wonderful board of clinical advisors, whether it's from the Turing Institute, whether it's from NHS, Stanford, Columbia, who are all working with us to figure out how we can maximize the clinical input in this app at the moment. So that's probably what I have to share today. Thank you. And any questions?
Yeah.
Shall I have one? Okay.
Yeah, Dr. Vishnu.
Yeah, excellent presentation. I enjoyed. How do you prove the clinical efficiency?
So I think one of the key ways in which we've done it so far is to use clinically validated scales that are anyway used within mental health and see real world populations whom we can observe. So whether that's a hospital trial or whether that's a trial in a school or an institutional. So institutional settings where we have access to the same individuals over a period of time and maybe access some individuals who haven't had access to this app and some who don't. So
how do you quantify the efficiency?
Yeah, so quantifying it using scales that already exist, such as say the PHQ-9 or a GAD. Those are validated scales that are used across the world, perhaps some culturally specific scales that we may want to use in specific cultural contexts.
Yeah, scales I have, we have an interesting scales in where they have done research, where they have the Marlin scale. The psychologists, where the children, they count them IQ is very good, they perform very badly in the school.
Okay.
So how do you say that their IQ is good, they should also perform in the school?
Okay.
So most of them did not perform. Is the assessment of IQ scale is wrong or is something to other things?
So I think intelligence usually has a significantly larger cultural context than something like distress, which can be found much more clearly and has a much more linear base across cultures. So usually those scales are easier to culturally validate across multiple contexts, as opposed to something like intelligence, which in itself is a complex construct.
So I think for the sake of time, we'll stick to last comment from Thomas, and then we'll move on to the next one.
So on one hand, this is extremely interesting and of great importance. On the other hand, it is difficult to see how this in its entirety can be validated. My question would be, is there an aspect to it that could be validated? Like, does the program have some inference towards a certain diagnosis and then acts according to it? So you could, for instance, say, okay, we think that's this diagnosis here is the case. So and we could potentially do that comparison, instead of the problem is the interaction, right? And then how do you, and the interaction changes the whole story. While if you have some predictor of the mental health status, that could be compared, and maybe the other one can be kind of derived from it. So it would be a test of something that's in the background instead of the whole interaction scheme. You see what I mean?
So given that our use case hasn't been diagnosis so far, but more as the reduction of distress by using something like a conversational agent, that's broadly what our research aims have also looked like. That when we look at validity of using something like a visor, what we want to make sure is definitely no harm. We want to make sure is that anyone who's using it has some metric of benefit that we can clearly evaluate.
I understand. I'm just trying to brainstorm with you what could be done here. Maybe that's not the right thing. So we'll take it off.
Would love to talk to you about this more.
Thank you.
Thank you.
So the next speaker is a colleague from Bangladesh, Professor Mamun, to share his experience and to share what he is working on in AI.
Thank you so much, ITU and Medical Research Council, to actually giving me the opportunity to share my experience. And I am not a doctor. I used to be a computer engineer, and then I did my PhD in medical engineering. And actually, I moved to healthcare due to the reason because of my mom. In 1992, while I was studying in school, my mom lost her one kidney due to mistreatment and misdiagnosis. And that time I have nothing to do, but while I started my PhD, that time my mom diagnosed with breast cancer, stage 4. And that time doctor said that she's gonna survive only 6 months. And like in country like Bangladesh or India, everyone like packing up everything because she's gonna go after 6 months. But that time I was like much mature. So I actually tried to take the informed decision. Like whatever we do in our life, if we make informed decision, that actually help us to make better things, right? So like based on the informed decision that my mom is still alive and she recovered from the cancer with the 6 chemotherapy. So that actually gave me the power that how information can change human life. So in 2014, I used to work in the University of Toronto. And that time I decided to quit my job and come back to Bangladesh and establish an R&D center and in the university. That R&D center will focus on healthcare using information technology like AI, machine learning, and so on, and helping the moms like who doesn't have the son like me to actually empower them, having the better healthcare. So that's why I started the lab in the university, and this is the first of the outcome of the lab is CMED. It was a journal paper we published in Elsevier, and this is commercialized now. So that's I just would like to share you the story of CMED is connecting people and saving lives. So you all know that NCD, non-communicable disease like stroke, heart attack is like a big challenge in our generation. So this is the things like while I'm doing research, that time it came out that 67% death in low middle income countries due to NCDs. And you can see only 1% of the healthcare budget is allocated for NCD. This came from the Bloomberg. But in Lancet, they published in 2016, the report that up to 90% of the NCDs are preventable. Like 90% stroke is preventable, 80% heart attack is preventable, and so on. So that actually, that triggered my mind that we should focus on the prevention of NCDs. So let's share some of the facts in Bangladesh. Bangladesh is a very small country. We are highly densely populated country, only 0.03% land of the world, and we share 2.5% of the population of the world. So you can imagine how densely populated we are. And healthcare expenditure in Bangladesh is $10 billion. I'm just giving the fact that it is very important. It could be similar to India as well. And every year, the patient growth in a hospital is 22.5%, and which is bad. It's not like a marketing, demand and supply, more demand and more supply. And what happening is everyone in the policymakers, they look in the top-down approach. They're building more hospitals because more patient is coming out. But we have to look into differently, bottom-up approach. We have to fix the problems rather creating more facilities. So another thing is there is no referral systems in Bangladesh. So if you are sick, you don't know where to go. You just ask randomly and get random information, and you just took one. And if you are lucky, you get good treatment. If you are not lucky, it will multiply your diseases. So, and as I said, in city, and WHO people are here, they always advises our government and other people that we can treat 80% of the population in lower facilities, but it's not happening. And our like secondary tertiary hospital doesn't have the space. And also we have a lot of paramedics who are jobless. So when I explored these things, I found that there is a demand and there is a supply. And there is a bridge between these two is the information technology. Our government took the initiative in 2008, Digital Bangladesh, and that is the key driver for solving these problems. So you see 63%. So to summarize this, all the problems, I grouped it to 4 problems. One is no referral system that's lead to healthcare into unknown, and not affordable because there is no insurance. In last year, it said that 50 lakhs people get poorer due to the meeting the healthcare cost, and also no health record. The problem is, if you go to the doctors, you have to say 2 things. One is what is your current complaint and what is your history. I seen my mom, she don't have 1 kidney and she's a cancer survivor. When I took her to the doctors giving her treatment without knowing her history. So this is the biggest problem. To address all the problems, we cannot solve all problems together, but we can start some point. So we actually developed a solution. It's called IoT-enabled, artificial intelligence-driven, cloud-based preventive and primary healthcare platform. What it do, it actually have an IoT-based sensors, smart sensors, that is a medical sensors that connect to your body and get the data to your mobile phone, and instantly you can get your health risk assessment. And it also sending all the data to your own health account. That is, I call it health inclusion. Because in our country, last 10 years, financial inclusion was so prominent, but now the time, I said now the time for health inclusion. If we create health inclusion, then we can keep all the record of my data. That will help to get informed treatment. And on top of that, they can actually, based on the data, we are trying to develop a risk prediction model for a stroke and heart attack. So you can see here like how we measure is an example here is your glucose. You put in the blood and it directly goes to your mobile phone, and instantly you're getting the advice based on the AI-based clinical decision support system, and it show you if the color code that you are healthy or you have a risk or you are in a high risk, you have to see doctors. And you can see here the kit, and kit actually includes all the necessary tools to have a good primary health care. So in Bangladesh, our people likes digital things. When digital things comes, it's easy to educate people. So it helps to educate people and NCD, and especially creating the referral for the next level of services. So as when we actually develop things, we try to do the pilot and then implementation. So there is 3 layers of service. One is the user, that I need to get service. But in Bangladesh, rural areas, people doesn't have the smartphones. So what we need to do, we need to have a community health worker who use the smartphone and kit and go door to door, creating the health account and giving regular primary healthcare service. You know, the NCD, the only solution is health monitoring. If you know health, if you monitor your health, you know your health risk, and you change your lifestyle, you can reduce the NCDs. So to address that, we created a health worker. They go door to door and giving the health checkup and advice based on the mobile app, and they act as a facilitator, and based on their health condition, they get the referral. And also the health report, they will get in every means of SMS, printout, emails, and in-apps. So now the question is, if any country doesn't have the good primary health care, their secondary and tertiary health care will suffer. So in that context, we actually segmented our 170 million population into 3 segments. Because in Bangladesh, we have many people working in a factory and corporate offices, and sadly, there is no primary health care in a corporate office and factories. So we actually utilizing the paramedics and the kit and app and setting up the kiosk in every factories or corporate offices to have a regular health checkup, creating the employee health account and monitoring, and they also getting the dashboard for all employees. And if there is any problem, they connect to a doctors through the telemedicine. And on the other hand, in a rural area, people doesn't want to go out. So for that context, we have a health worker who go door steps and give the primary health care service. When needed, they can refer to doctors. And on the other hand, this is the biggest problem in Bangladesh in the pharmacy. If someone have a medical attention needed, they go to the pharmacy, and from the pharmacy, most of 65% cases, they get the prescription medication without the prescription. So this is the biggest malpractice. So we are trying to solve this problem to creating our platforms to, when they go to the pharmacy, they will use the app and the kit to assess the people and connect to the doctors, and then doctors give the prescription, the pharmacy salesman do the dispense the medications. So these are the modality. So we already implemented the first one, the corporate one, and the health assistant one, and we are working on the pharmacy one. So I will share you just one example what we did. In 2018, we partnered with the NGOs to implement the health worker model in a rural place. You can see here that we have a red one is a household. Every house, like every 500 household, we have a one health worker. So health worker go door to door and then give the health services using the app and device. And if they have needed attention, they refer to the medical assistant in the next level. And medical assistants see that the problem is severe, then they will connect to doctors. So in Bangladesh, it is divided into like 4,554 unions. We implement pilot in one union for 1 year, and based on the success of the one union, we are scaling it to the like 50 unions at this moment. And if you allow, I would like to show you the video that it came out in the national news, and that how our systems works, and it could be a learning for everyone. So just could you please play the video? So I think there's no sound. So I think there is no sound. You need to just read the titles. I think it's fine. So this is a health inclusion for everyone in every area. You just read the subtitles and I will help you to understand. So this is our first union where the 21 villages in one union have every citizen have their digital health account, and they're getting regular health checkup in every month. And not only health data we're getting health data, socioeconomic data, environmental data, and so on. More than 100 parameters is coming every month. So we can, from the data, we can see that what's happening and what are the most severe things and what is the good things, what correlates to what. And it is the project is subsidized by the NGOs, and the family need to pay only like $1.5 for a month, for a year at this moment. But we calculated it, if it is in $1 per month, then it is fully sustainable without any subsidy. And you'll find the interesting fact is, before doing that, it was like only 2.7% of the adult population, they know they are diabetic. But after 6 months of study, it came out that more than 50% people, 15% people are suffering diabetes. And again, for the hypertension, it is like they know only 6% people are suffering diabetes. And after all the regular checkups, it came out that more than 11% are suffering like hypertension. On the other hand, the obesity and malnutrition also very severe in that context. So I think I can skip it and you can see it later. So what I'm saying that, so we actually in this year, we are covering 50 unions, and every citizen of 50 unions have digital health account and at least one checkup every month for 1.5 million population. And we created 2,500 jobs through our systems. And according to our agreement with the 200 NGOs, and we are covering more than 200 unions by next year that cover more than 5 million users. And you can see that the data will coming out, that they're all authentic data, and we will use for the risk prediction models and so on. So we are in the in talk with the government infrastructure to utilize the similar model for government health services. So we in my lab, there is other projects is going on that how AI can help us to screen eye and maternal child health, and as well as the Parkinson and Alzheimer disease. Because I believe that if we can do the early screening is a key to prevent a lot of sufferings and diseases. So that's like I always working on. This is a team we are working. So as I said, that an interesting fact is this is the only initiative in Bangladesh that actually commercialized from the research. And we actually got a number of recognitions nationally and internationally. And what we believe in, like our initiative, that we want to connect people and saving their lives and continue their smile. Thank you.
That's quite impressive, Professor Mahmood. So I think we are short of time, so we'll quickly move on to our two presentations. Next, you want to ask one question? Only one then. Okay.
Yeah, thank you so much for sharing this fascinating, big initiative actually. I was just wondering, I was curious about your experience. So now it seems you have a way to have more diagnosis, so people know what's wrong. And my idea would be that probably the next problem is that there's difficulty to get treatment. Is this the case, or is this new information actually helping people to improve their health, or is this then just an information and then I don't know, they still don't have access to healthcare? So I would be curious.
Thank you so much. It's a good question. It have two things. One is they're getting the right services and they are educating. So we have actually published a research study in July that how the digital healthcare can help the NCD and feasibility of digital healthcare for preventing NCD. And what we found that the rural people, they are not educated. Now based on the awareness, they are more serious about their health. And I'd like to share you one example. Like one lady, she is a housewife, and our app advised her that she have to lose 5 kilograms of weight, otherwise she have a risk of diabetes or hypertension. And now she walks half an hour every day, and she's saying that mobile tells me I have to do it, otherwise I have a risk. This is one side. Another side is we have one doctor in every union. So whenever they have a complicated problems, they will refer to doctors, and doctor give the prescription, and our health workers do the follow-up. So as you rightly mentioned that if they know and they don't getting the service, that is a problem. In Bangladesh, we have a very good resources, but resources are not utilized in a structured way. So that's the case. I think it answers your question. Thank you.
Okay, thank you, Professor Maman. So our next presenter is Ms. Arpita Singh from Dr.
Good evening, everyone. Just a disclaimer before I start. I'm going to skip a lot of my slides because I want to make sure that I'm in time. But introducing Docternal to you, it's a platform for non-invasive point of care for lung-based ailments with oral components. Our flagship product, a brief look at why there was this need of creating this product. 10 million people, known cases of TB in the world, out of which 27% are in India alone, out of which we know only 1/4 of the number. There is an increase of MDR TB cases, and there is a requirement for something that can at least help us identify the cases that we've not been able to identify. So introducing Timber, the mechanism is very simple. It's a smartphone attached to a microphone where a person coughs, and along with this, their demographic and clinical variables are recorded. Demographic variables such as height and weight, clinical variables like appetite loss, fever patterns, and cough patterns. This then gets processed by AI to provide you results in 3 minutes as to whether this cough is TB or not. Now, this is our current state. Where we will progress from this is if it's not a TB cough, then what is it? Is it smoker's cough? Is it COPD? Is it TOPD? Or is it bronchitis? Why it works is because it just has a small microphone attached with a wire to the smartphone. Its unique selling point is that even if you're in a remote location which does not have any connectivity, you can still use this app and record the data and then get it processed later. It's absolutely integration, connectivity, infrastructure, system, and geography agnostic, so it can be used anywhere. Which means, and you can integrate it with any hospital applications or any M-Health applications as well. The magic behind is machine learning and deep learning, and one of the key things that we use this for is adherence. I'll give you a small example. We recently did a small cross-validation of our results along with GeneXpert. And what we received was an 85% accuracy, where sensitivity was oscillating between 80 to 85, and specificity was at 92%. We were using this for prognosis and showing adherence, because what we realized was the GeneXpert results were taken in January. We did this test in March, and it came negative. When we resent it for GeneXpert, it again came negative, demonstrating that the treatment that the people were taking for TB was actually, they were responding to it. Why we are ahead in terms of competition, it's real time, it's POC, it's objective, less cumbersome, and we ensure that this is something that reaches the last mile, where case identification becomes easy. So today we don't know where people are, whether they have TB or not. Now we have a means to go to those people and say, you know what, just screen for this. And you can at least identify which case needs to be taken for further processing and which case needs to be just left where they are. Our plans are pretty simple. We are looking at pan-India deployment within the next 6 months. And post that, we are looking to expand to higher burden countries which have TB as one of the major problems for them. We are at a sample size of 7,000, but for our calculations, we only use about 3,900 samples. This is a mix of healthy and unhealthy samples. When the person is coughing, we keep in mind both voluntary and involuntary cough. That's our team. It's an amalgamation of data scientists, medical doctors, marketeers, and operational experts. Our board of advisors, inclusive of eminent doctors of the country. Just a quick look of what happens. So once the result comes, the physician actually gets this graphical representation of the results, where there's clear indication of what may be the features, what are the factors that have been taken into consideration, and what is the actual result. These graphs here are for representation only, but to the physician, this entire result is provided in detail within 3 minutes. Thank you so much for your attention. If time permits, I'll answer a question.
Thank you, Arpita. Any questions?
Yeah. Please stay there.
Seems you want to ask a long question.
No, I don't ask. So that clinical trial registry, you said, are you registered a RCT, or you are taking the open source of clinical trials information from CTRI?
No, sir, we are registered.
You're registered.
Yeah.
A really quick question.
That was my timer for 5 minutes.
Can I ask just one really quick question? I'm super impressed by this because TB is notoriously non-specific. So I was also wondering how much of the accuracy comes from the cough and how much from the questions that you asked, and whether or not you know the increase in accuracy from the cough.
So, well, the information that we ask for definitely plays a role. Why it helps us is because it makes the result more conclusive. If you were just taking the cough, we'd probably be still stuck with the sound of the cough. But now when we add on to the clinical and demographic variables, it becomes more conclusive. We are still a screening tool, but it's our ambitious plan to become a diagnostic tool at some stage. So this is in preparation for that.
A small correction, you said weight and height as demographic weight. They are not demographic. Weight and weight is anthropometric weight.
So we'll take that feedback, yes. But we calculate it for the BMI, basically. Okay, I'll keep that in mind.
Thank you, Arpita.
Can I ask?
Last presenter.
last talk before we all break. It's always a tough task. I'd like to start by thanking ICMR for this opportunity. We're a small research group based just down the road, and Caring is our name. I'll just walk you all through our journey and what is it that we are building. So Mahajan Imaging is our parent company. It's one of India's leading medical imaging providers. We do about 400,000 patients every year, mostly high-end work, about 50 radiologists, all based in the Delhi region. We have significant media coverage because we keep doing new and interesting things, some of which I'll just walk you guys through. We became about 6 months ago, arguably the first place on the planet to install a bunch of next generation sequencers within an imaging facility. I don't know if that's a good thing or not, but we'll soon find out. The idea is to merge molecular imaging and molecular pathology and genomics to finally reach that eventual endpoint of molecular integrated diagnostics. And we are trying to make small steps towards this journey. Several of our partners are either in this room or in the city, and time will tell what we are trying to do. Today I'm here to talk about Caring. Caring is the Center for Advanced Research in Imaging, Neurosciences and Genomics. We essentially work with a group of collaborators from all across the world. We are very, very proud of all of our collaborations. It ranges from academia, academia abroad, academia in India, to the large companies, GE, Philips, NVIDIA, several startups. Cure.ai is one of our most prized partners. And then a bunch of startups from across the world. And what we bring to these startups is a unique mix of clinical, scientific, and product expertise. So we are actually a very small room in which 10, 12 of us sit. But within those 10, 12 people exist clinicians, scientists, and product people. And that has led to some good work. So this is again the Lancet paper. We were privileged to be part of the team that got published this. Then we had a paper in the American Journal of Odontology on concepts for US FDA written by a bunch of Indian people, which is very interesting. Then we had, which is again, we believe the first paper on unboxing AI. It's by Vasant, he's in the audience, on how can we give clinical/radiological insights to the functioning of a deep learning algorithm and then go backwards and try to say what the algorithm actually saw. And then we have a paper that's just gotten accepted to academic radiology on algorithmic auditing. So how do you actually look at the functioning of deep learning algorithms from point of view of trying to figure out have they actually crossed a threshold where they can become clinically useful. And thanks to all of our collaborations, we have a lot of presentations across the world. This is from RSNA last year. RSNA is the Radiology Society of North America. It's the mecca for radiology. Then we were there at the European Congress of Radiology, and then we'll be there at RSNA again this year in great presence. What we've built is Carpal. Carpal is it's an acronym for Caring Analytics Platform, which is essentially a computer box that sits in either your hospital or your department or wheresoever you may choose to be, and it helps you develop, test, and deploy any kind of AI solution restricted to radiology right now, but in the clinical domain. And how does it do that? Well, there's a whole host of AI solutions out there. On the left-hand side, we've tried to categorize them into deep technology, workflow tools, and data mining tools. And on the other side, there's the whole provider ecosystem. We are trying to be the unifying force between these two. And this is what the platform looks like. It essentially puts the power of AI into the hands of the clinician. But at the very start, we emphasize a lot on validation, because every hospital, every clinician has to test AI, no matter how many papers there are of that AI algorithm. If it doesn't work in your clinical situation, it doesn't work at all. And similarly, on the development side, we are doing a lot of work on merging imaging and genomics. On the testing side, you can see our platform downstairs after the talk. But on the testing side, there's tuberculosis, a lot of work being done on that. And then on the deployment side, we're deploying these algorithms for screening for lung cancer and a lot of other things. This is just a concept that we have where we can use retrospective data to create country-level temporo-geographic heat maps processed through AI. This is just the last slide. Imagine the possibilities when all these sites can, across the world, all healthcare providers can be on a same unifying analytics platform, both for uploading data to the cloud or downloading algorithms. That would be a great day. Thank you.
Okay, so we've come. Okay, Dr. Andrews.
Now, which way it, Mahajan, which way it is useful for the common man? Okay, you have published great publications and all. So, which way it is going to help a common man to go a cheaper kind of a thing?
Sir, so these techniques will all drive price down, right? As price comes down, all common people will benefit. For example, we already have systems in place where X-rays are being read automatically. Not just in a research setting or not just in a screening setting where, as Professor Brahmachari was mentioning, that nothing exists. Like they are being read in our institute, normal versus abnormal, because 50% of all X-ray is normal. So if we can do a normal versus abnormal delineation, and eventually cost of reporting goes down. Similarly, we're working on spine MRI. 50% of spine MRI is also normal if you can delineate normal versus abnormal in that. So once the algorithms become democratized, they eventually come to the patients. But our singular focus is the clinical side of things.
Okay.
Sir.
The data you had, your health organization is one of the first imaging institutes in the country, I think. So it's been about 30 years.
Yes.
And you have this data with consent from the patients?
So about 5-6 years ago, we started taking consent from each of our patients. That de-identified data from your study today may be used for third-party product development or R&D purposes. So at least we have it for about 5-6 years. So that's why we are able to. So in
by
fact,
any chance, do you have beyond radiology data, such as?
I wish.
Or you don't have that. Okay, we need to talk about that. Thanks.
Okay.
Thank you.
Thank you, Dr. Vedot. So I would like to thank all the presenters and my co-chair for the session. And so we move on to the closing session, and I would like to invite Professor Thomas, who's chair of Focus Group on AI for Health, Dr. Duteja, who's Additional Director General in Council of Medical Research, and Mr. Rajiv Roy, who's Senior Financial Advisor, to come on the dais and address the gatherings.
Thank you very much. So due to the interest of time, may I suggest that we keep this brief and discuss the action items that resulted from our workshop that may be of interest. So if you go to the next slide. So first thing I would have is an ethics working group. We had a long ethics panel. I think we need to get this set up. Lucky for us, WHO has set up an ethics working group exactly on AI. If things work out, we can basically mirror that group, basically have the same people run the ethics group for the focus group if we decide that to do tomorrow. A clinical evaluation working group should also be something that we've seen from today's work, and Naomi, I think there are some ideas how to set this up so that it gets rolling. Then I have a question, so should we have a tuberculosis audio topic group? Right, I think we had 2 presentations on this, which makes it a great starting point. If you are interested, and who was the other presentation? He has left. So if he was interested, so if you're interested, you both could get together and form this group, because that's a very important topic, and its efficiencies can be well recognized. And if there's a way to for you to work together and get this into the process, that would be amazing. Then maybe again this time the child growth monitor topic group. We've had 2 attempts and it didn't work. Maybe 3rd time is a charm. It's a topic very close to our hearts, and we should get started. So who was that who presented the child growth?
Yeah, I think he has left.
He's left, so
He's
but
from
he
Madhvani AI, but we can contact him.
and he said he would be interested,
Yes,
right? Yes. And then a pregnant
tomorrow, or no? I think he won't be joining us, but we can communicate on email and.
Yeah. So and then the last topic group that came to my attention would be a pregnant woman screening topic group, which maybe
part of the maternal health.
That was the I think. Yes. I just took my notes and I thought that would be also one thing that we should be looking into.
That can be part of the maternal health group.
Yeah?
Yeah.
The mental?
Maternal health. Maternal health.
I was just wondering how mental health, that doesn't work.
But that's because of the evening, 7 o'clock. So
okay.
It's nothing to do with what I am saying and what you are listening.
That would be part of of that. Okay. Well, that's good. So, yes, Samir?
That was my only proposal would be to keep TV level also, not to take specific to audio components.
Audio.
Child growth or something, I think even child health as a group.
Yes.
Child health.
Okay.
And then bring them together so instead of making too much bifurcated.
So we would add the audio-based diagnostics to the TB topic group that we already have. Yeah. Okay, that's a good idea. Yes, please.
And then maternal health also.
Maternal and child, that's what he's suggesting, because they generally go hand in hand.
Yeah, but they are, okay, I'm not going to argue with you guys over this now. I'm just saying that they are, from a computer science point of view, they are very different objects, yes. The mother and the child. All right, so good. Please, first you and then you.
Yes, I think we'd be interested in whether there is space for a health financing or insurance working group. I don't know if that's out of scope or not.
Oh, so what I suggest is to better understand the actual topic. Like, what is it that you want to be done? Are you going to be here tomorrow?
Yes.
So we will discuss that then. So the best way to kind of get our feet on the ground would be if you could provide us a description of what you want to do. We really can't create a topic group or a subject without a documentation. This is one of the conditions for our work, is that we provide documents for everything so that people can, in retrospect, follow and see what happens in the past. So if you could provide us a document by tomorrow, night is still beginning, that would be amazing.
Okay, are there templates on the intranet site?
Yes.
Could you point it? I'll follow up afterwards.
Simao here, maybe use the microphone and say it.
Yeah, you should fill in the proper proposal document. We need to see the there is a template that you fill in there. So there are several questions you have to kind of try to address. That kind of explains what you can be accomplished with the scope of the program.
If you want, we can take this offline.
Yeah.
Talk later.
So then you and you.
So like I'm more focusing on primary healthcare. So there is you said the.
I'm going to get to your point. I have another bullet below. So can you hold that? And then if it's not covered, then we'll get back to you. Yes.
Okay, I was just wondering how we're separating topic groups. If it's from a computer science perspective, then I think, or if it's from a benchmarking perspective, then I think the TB audio group should be separate from the TB group, mainly because of the data types that are involved. There's different things that happen as you're trying to benchmark these different tools.
All right, we'll discuss that tomorrow. So the next thing I have is the collaboration methods with mobile platform on data and AI topics. That would be what you just presented, right? So I can see that there's a huge potential, but there's also a huge number of questions. For instance, the data that you are collecting, to what degree can they be involved into the AI training testing framework that we are working on here? if those people were in Europe, it would be a big no. If they are in Bangladesh, maybe it's a big yes, because it's seen differently. That's something that we have to consider and be thinking through. Platform used in the global south to evaluate things, right? It's very critical, this aspect. But on the other hand, we want to bring
we take account and their health account data only accessible to them,
yes,
himself or
yes,
herself,
yes,
and other people who want to see the data, they will need to give the consent with two-factor authentication.
Oh, cool. That's good.
So, like, ethical issue is in place, and
yes,
in the platform we follow GDPR and HIPAA.
Oh, great.
So that's the thing. So I think that issue can solve. But I just adding the few things like when I'm focusing on primary healthcare is a broad thing. So in that AMC.
Let's say a consideration document on collaboration with mobile platforms like the one that we've seen from Bangladesh.
Yeah, I'm not on a colleague from Bangladesh as well to help and join and support that work so that I can jointly do that instead of me just doing it.
Yeah. But Samir, could you coordinate that from the focus group side? So then I have another topic, formats for data transmission for remote AI. We already mentioned that. It's something that may be of relevance. It may not be that we standardize these formats, but it may be that we include them into the benchmarking. So if a picture is transmitted and it's compressed, maybe too much compressed, then the AI may suffer from that. And we'll have to maybe have a feature saying how much you can compress a picture to use it for certain diagnostic predictions. And the last topic I have is basically the requirements for an app for collective data annotation. So in a way, we are creating best practices on data annotation, a document. But then there's the question of how do you make it in a collaborative way so that it comes from many sources, can be brought together very efficiently. So what I'm imagining is that there's a task description, like this is the annotation task. And then there is a way of registering if you are a qualified person to do this. Let's say you are a pathologist and you're qualified to do this. There's a way of registering. Then you can basically spend the task online according to the annotation specification and put up possibly additional software tools where you would be doing annotations and markings and whatever is in the description. You submit. We have a way of quality checking your annotation because we may give the same annotation to multiple people, so we can quality check consistency, etc. And that way, basically provide a tool that would be serving as a best practice, not only for just annotation for a single person, but for annotation for a collective, a medicine collective. And we talked about it earlier, so you said you would volunteer to start looking into those requirements. Yes, and I know of an app like that currently being developed at the ETH Zurich, and maybe if we pass on the requirements, they adjust it, or maybe we can use some other app that's out there, and it would be a great thing to have, like to facilitate these steps that we are making here, because the best practices may not only apply to the annotation process itself, but may also apply to the collective aspect of the annotation process. So it comes from multiple sources, and 7 pathologists and 14 opinions. So that's my summary. Is there something more? Please use the microphone.
Well, it was already there. Oh, I didn't see. I was asking, shouldn't there be a group focusing on regulatory aspects?
Oh yeah, we already have a group on regulatory consideration. We already produced lots of documents. We are marching towards this quite heavily because we see this as one of the early uses of our work. Please.
Yeah, I just wanted to suggest that there should be appropriate clinical practitioners in all these groups as relevant. I think you should include the practitioners and the people who are supposed to use the AI tools right from the beginning, if possible.
Yes, definitely. We don't want to have computer scientists doing your health work. That's not a good idea. Please, Samir. It's too complicated.
Call out on that statement and the revisions. These are working groups which have been created, and you're welcome to join these working groups. I mean, everything on the website, all these working groups, they're not restricted to 1 or 2 people. We want more and more people, and that's why I'm calling out. The regulatory work has just started in March. Maybe that's your pitch, Thomas and Srini, but I just wanted to make this announcement here that if you are interested in specific areas or in broader, please come up and send an email to the working group and we can.
Yeah, I have one more request to make. Whatever tools like apps and any software tools that you are going to make for annotation of the data, I think they should be available in the public domain and as open source so that any other institutions can also make use of them and annotate the data, and sometime they may join the pool, the data pool.
That is precisely the goal, to make them open source and publicly available, and we hope they can be used as broadly as possible.
Yeah. Thank you. Thank you.
Is there anything else? I for sure forgot something. Oh, there you are.
Dr. Samir is saying that there will be a specific document or a protocol what you want to have for collaborations, what we are looking at here.
Yeah,
the private entities and so.
Tomorrow we will be discussing our outputs from the focus group, and one of them is going to be regulatory considerations. We already produced 2 big documents. One is on 80 questions of AI regulation, and the second one is we have mapped the essential principles of regulation to AI tools. We just discussed over email whether we should be mapping the ethics principles that came, for instance, from the EU in 2018, map them to AI tools, but there are other papers, so we may also want to do that exercise. The reason for these exercises is that we kind of systematically see if we have considered everything necessary from all those perspectives: ethics, regulatory, legal, etc. Yeah. Okay, anything else? Well, I would like to thank the organizers for the hard work in organizing this, as it is probably the nature of interactive workshops that they develop some dynamic, and we are a little bit over time. We are now not done yet, as far as I understand. We now see demonstrations, and then there will be a reception afterwards. Is that correct? Or we just see the demo? Is there going to be a reception afterwards?
Dinner.
Dinner. Okay, it's perfect. So if there's nothing more, I think there are quite a few thanks in Manjula, could you maybe help me in thanking all of those who helped organizing this? Okay. I thank you first, and then you please thank everybody else. I don't know who to thank.
Okay, so I think I would like to thank everyone from WHO ITU group, of course the chair, vice chairs, and everyone, and all the presenters and the participants who have really, made it a success. And with this, I would request, I would like to thank my, Director General and our seniors, our additional DG, and Mr. Roy, who's the man behind the show, because he has really put in all the efforts, and whatever you're seeing here today is is because of him, that this workshop is a real success. So with this, I would like to request Dr. Tuteja sir to say a few words, and of course then Mr. Roy to finally conclude the session. Thanks.
And let me maybe add to it. I have to say, I thought the atmosphere that we had was extremely constructive and positive. Everybody was sees this as a contribution to move things forward, and I felt that today. So thank you for that.
Okay, thank you. What do you expect from the seminar? First thing is good audience, wonderful audience we have. And it is 7:30 and I see around 60 people are still sitting. At 6 o'clock, there were 78 people I counted. And all are very attentive. And it doesn't look like that it is the end of the day. It looks the beginning of the new session. Everybody is fresh. Good presentation and good discussion. And promise for future. That's what you don't need more than that. So I would like to thank all of you for coming all the way to India and Delhi and ICMR and making this seminar a success. And a special thanks to Professor yourself, Dr. Manjula ji, and of course Dr. Chandrasekhar and our senior FHA, Rajiv. They are the people, other people who make this success. And also acknowledge ITU, WHO, ICMR once again. Thank you very much.
Friends, I won't test your patience anymore. So just 2-3 lines. When we conceived about the symposium, the idea was to provide a common platform for all the stakeholders. And I'm happy that we were having clinicians discussing application of AI tool. We were having engineers, technocrats, economists, data experts, legal experts, and last but not the least, the innovators, the industry people. And as Dr. Tuteja rightly said that the number, it speaks about itself. So I also consider it to be, we can safely conclude that it was a successful symposium. But this is not the end. This is just the beginning for a new era. And I promise on behalf of ICMR to provide and create many such opportunities in future. And I would go on record that we were a little unfair to all of you to restrict you within these 4 walls since morning. But the kind of enthusiasm which you people reflected was commendable. And just to compensate for these 4 walls, we have organized a dinner outside in the lawn. Hope you will enjoy Delhi evening. And thank you very much, and request to join us for a demonstration of innovators. They are eagerly waiting for us to go and see their innovations. And just in front of that, we are having an open lawn where we have organized a dinner for you. Thank you very much. Thank you once again.